Chairman. When we see this patient complaining of radial side wrist pain dating since 2 years, always we think of open and grafting these defect and rigid fixation to allow healing. However, many times we open these patients and we find an intact cartilage cap and stable fibrous non-union. So the idea of percutaneous fixation of scaphoid non-unions dating since 1970, since Sterali of Austria started to fix these fractures percutaneously. But poor results was achieved due to using of large-headed screws. And all his patients had scaphotrapezial arthritis. But now with the recent advances in fixation of the scaphoid with headless screws, this condition does not occur. We performed percutaneous screw fixation for scaphoid non-union in 15 patients, 14 males and 1 female, an average age of 28 years, and the interval between injury to surgery was an average 15 months. Inclusion criteria included stable non-union of the scaphoid, non-displaced established non-union with bone resorption at non-union site. All the patient has bone resorption at non-union site. Adequate bone stock is required proximal and distal to allow for screw purchase, maintained carpal height and scapholunate angle, and no humpback deformity for our patients. So 6 months at least from the time to injury, and there is no upper limit. Extensive bone resorption or sclerosis at the non-union site was not considered a contraindication for the technique. We assessed the gap size by the largest gap diameter in a posterior-anterior view with ulnar deviation with a line parallel to the axis of the scaphoid. Rigid fixation alone with a headless cannulated screw, Herbert's, volar retrograde approach is chosen, and no bone grafting. After that, we apply short arm cast without involvement of the thumb for 6 to 8 weeks, and then followed by removable splint for 4 more weeks, and we avoid contact sports till union is achieved. This patient, 2 years, trauma since 2 years, and screw fixation only, and union occurred in 10 weeks. And this patient also, the gap size appears larger in the CT than it appears in the conventional X-rays, and fixation alone achieved union in 12 weeks. Also in this patient, and in more proximal fractures. Apparent scaphoid displacement, we can see in the middle picture, is not a contraindication to the technique, and sclerosis in the surrounding can be micro-drilled using K-wires during the time of percutaneous fixation. Screws applied and union is achieved. This is a limitation of the approach if we have significant defect with dorsal displacement. Also, if we have established through arthrosis in which we should use strut graft to compensate the dorsal displacement. Also, scaphoid non-union advanced collapse is a contraindication for the technique. The results, we achieved union in the 15 patients in a mean 11 weeks. Bone trabeculae crossing the fracture site in a 5 scaphoid views, and immediately thereafter confirmed by the CT, was considered a sign of union. There's no correlation between the gap size and the time taken to union. Preoperative Mayo wrist score improved into 13 excellent and 2 good results, and visual analog score for pain improved from 4 to 1. Conclusion, selected non-union, non-displaced scaphoid non-union with gaps requires only rigid fixation to achieve healing, provided that there is no carpal malalignment and good purchase of bone could be achieved. Extensive resorption and gapping at the fracture site is not considered an absolute indication for bone grafting. Percutaneous fixation alone eventually ends in bone healing, regardless of the gap size and the duration of non-union. However, proper selection should be chosen. Thank you.